Hello and welcome to this educational video. This video is intended for frontline staff who are responding to a code blue. So that would be just about any RN, LPN, PSW in our building. So when you come upon a patient and you've done your quick assessment that you need to call a code blue, you can pick up a phone. Any phone in any room will work. It doesn't matter if the patient has connected or not. You can call 6666 and you will state code blue. If this is a pediatric patient, meaning the patient is less than 16 years of age, you will say code blue pediatrics. That will initiate a nursing response from the emergency department regardless of where the patient is in the hospital. If it is a pediatric patient, the emergency room nurses are best equipped to manage that patient. It will also prompt the staff in locating to call the pediatrician on call and call him stat or her stat. So when you are calling, you are going to say the level that you are on. So level 5. There are 4 towers in our building. A tower is called Alpha. B tower is called Brava. C tower is called Charlie. And D tower is Delta. So you would say 5 Alpha North, room 71. Code blue, 5 Alpha North, room 71. And again, if this were a pediatric patient, then you would state code blue pediatrics. That's very important. When you first come upon a patient, you are not going to have a code blue cart. So what you as the floor staff can do is determine, is there a pulse? No. Then you will hop on the patient's chest and you will deliver compressions at a rate of 100 to 120 per minute. You do not need to put your mouth on the patient. You will deliver hands-only CPR until your colleagues arrive with an airway basket. If there were a mask in your room, you could use that to deliver the breaths. But if there is no airway management equipment there, do hands-only CPR. So the ideal code team is 6 to 8 members. Any more than that really hinders the resuscitation process. So you need a team leader. You need somebody to do compressions. You need an airway manager, somebody to man the electrical therapy, also known as the defibrillator, a medication RN, and also a recorder. But remember, CPR is a very physically taxing exercise. So at the 2-minute mark, when we assess our rhythm, you should switch out. Even if you don't feel that you're tired, your compressions have decreased in their significance. So you need to step aside and let somebody else come in and take over the compression role. Working as a team is very important. If you are on a floor, there are 30-some other patients that need to be managed. And oftentimes these patients know that a crisis is happening on your floor, so they have heightened anxiety. So if you are not needed in the room, please attend to the other patients on your floor because they will have a higher anxiety level. Following this little introduction, we are going to talk about the role of each of the team members. So it's my pleasure to introduce to you Dr. Alex Saunders, who has volunteered to be our code team lead today. Thank you very much.
Hi, I'm Dr. Alex Saunders, and I'm the leader of the medical response team. My role is important in that I'm the one that organizes the code and makes sure that the resuscitation happens in an organized manner. The code leader should be assertive and knowledgeable. So when I arrive, remember, I'm a resident that's just coming on to the scene, so chances are I don't know this patient. I don't know anything about their past medical history, nor will I know what's happened in the code so far. So it's going to be important for me to get a summary from a knowledgeable nurse on the floor as to what's happened and what's going on with this patient. Deb is going to give an example of a good patient report. Hi guys, I'm Dr. Alex Saunders, the resident who's on call for internal medicine tonight. So I see you guys just shocked someone. Can you tell me a bit about this patient?
Doug is a 64-year-old man who had ileocondylar surgery 2 days ago.
Okay.
He's got a history of diabetes, peripheral vascular disease.
So that report by the RN was very helpful because that gives me an idea as to what's going on with this patient. So now that I've got a bit of the story, we'll continue with the code and see what we want to do next for shock, which medications we want to give. So we'll want to have epinephrine, possibly amiodarone ready to go, possibly some other medications. And we'll want to know a bit more about their past medical history and do a bit more of a secondary survey.
The role of the compressor, person providing CPR, is very important. The compressor must provide compressions at a rate of 100 to 120 beats per minute and have enough upper body strength to compress the adult chest at least 2 inches. My compressions need to supply enough blood flow to perfuse the head and the heart. Providing compressions is a significant physical workout, and I need relief every 2 minutes. During CPR, I must also count my compressions because at the end of the 30 compression mark, I will pause for the airway manager to deliver 2 breaths. If the patient receives an advanced airway, such as an endotracheal tube, the compressor will deliver continuous compressions for the 2 full minutes with no stopping for breaths. Using a stool or getting in the patient's bed will enable you to be directly over the patient, and this will optimize your compressions and minimize muscle strain to your body. Using a stool or getting in the patient's bed will enable you to be directly over the patient, and this will optimize your compressions and minimize muscle strain to your body.
The role of the defibrillator requires special education and certification. As a registered nurse trained in defibrillation, I am able to shock pulseless ventricular tachycardia and ventricular fibrillation in the absence of a physician. The LifePak 20 defibrillator has a 1-shock protocol where 1 shock at 200 joules is offered, and if unsuccessful, it is followed by 2 minutes of CPR. The second shock delivered is at 300 joules, and again, if unsuccessful, followed by 2 minutes of CPR. All shocks delivered after this will be at 360 joules. As the defibrillating RN, I will rely on the recorder to let me know when the 2 minutes are almost up. This will prompt me to charge the machine in preparation for shock delivery. When the crash cart and defibrillator arrive, I will work around the compressor and place 2 defib pads on the patient, 1 above the right nipple and 1 below and lateral to the left nipple. The compressor should not stop until they hear me say, "I'm clear, you're clear, we're all clear." Once delivered, I will look at the recorder and state 200 joules delivered. With this defibrillator, I can also pace a bradycardia or convert a tachycardia. For these procedures, I will need to add the ECG electrodes to the patient's chest. When my patient was not alive, I did not need to add the ECG electrodes since the large defibrillation pads allow me to see the rhythm through them. However, pacing and cardioversion require delivery of electricity on a specific part of the QRS complex, and ECG electrodes are required.
The RT is the airway management expert in the building. They may ask for some assistance from you if an advanced airway is required, like intubation. All of the equipment for an advanced airway is in the airway drawer of the crash cart or in the basket that the RT brings to the code. The airway manager is most often a respiratory therapist, but the floor staff can manage the airway until we get there. Now, in your regular BLS recert, you're taught how to use a manual resuscitator and mask, but that may have been more than a year ago. So I'm just going to go through the procedure for putting in an oral airway and using the bag mask device. So put in the oral airway, you measure from the corner of the mouth to the corner of the jaw, and this is inserted upside down and then twisted into place. You just settle it into the mouth. For the bag mask device, you have your bag and your mask, use the C&E technique. Roll down over the nose, over the mouth, C, hold the jaw, and then you deliver 1 breath, over 1 second, and then a second breath until you get chest rise.
Interosseous devices have been added to the IV drawer of all official crash carts at the St. John Regional Hospital. The first drug that is typically prepared during a cardiac arrest situation is epinephrine 1 milligram IV. Allow me to demonstrate how to prepare and administer 1 milligram of epinephrine using a pre-mixed syringe. In order to prepare 1 milligram of epinephrine, the box must be opened from the bottom as directed on the label. Then the two pieces can be removed from the box. The yellow cap's removed. And then the glass part of the ampule can be screwed clockwise into the barrel of the syringe. And now the medication is ready for rapid administration, either through a system with a needle or a needleless system. For a needleless system, remove the yellow cap. The injection site closest to the patient can be prepared and the medication injected rapidly. Almost any drug given in a code blue situation is given undiluted via direct IV push, including amiodarone for ventricular arrhythmias. Atropine, magnesium sulfate, calcium chloride, and sodium bicarbonate can all be pushed in the pulseless patient. Once you get return of spontaneous circulation, then drug administration will have to follow the drug manual.
The recorder is an RN or an LPN, and they are often the nurse working on the patient care area. The priority for the recorder is to apply these lapel labels, and there is a lapel label for the code team leader. There is one for the nurse manning the defibrillator. There is one for the airway manager, the medication RN, and then finally, labeling yourself. The compressor does not have a label, as he or she is replaced every 2 minutes. Identification of key personnel is intended to assist the team leader in providing clear direction to the team members, but also assist the team leader in identification. Recording the resuscitation process can be a very intimidating but an extremely important role because of timing and sequence of events. The recorder must be able to time between the shocks and alert the team when they are approaching the 2-minute interval. Shocks are delivered at a 2-minute interval. All interventions are centered around giving 2 minutes of CPR, whether this be a pulse check or a delivery of a shock. Just prior to the 2-minute mark, it is the recorder's responsibility to state, "Coming up on the 2-minute mark," in a loud, assertive voice and looking directly at the team leader for acknowledgement that the timing indicator has been heard. Following our Code Blue demonstration, I will provide a comprehensive overview of how to complete a Code Blue documentation sheet. This is a legal requirement, but also an important component to understand what has occurred in the resuscitation attempt. In a perfect world, it would be wonderful if you could ask each team member at the end of a code if they could write their name on their sticker and give them back to you. At the end of a Code Blue document, you could place each of these stickers with the corresponding signature, and that would enable you to have that person's signature on the legal document. The following is intended as an